Moving on with our next presentation, which is a long case presentation about a patient with obstructive jaundice posted for Whipple surgery. And we have a very eminent, learned examiner with us as an external examiner for this case discussion, Dr. Nidhi Agarwal. Ma'am is professor in the Department of Anesthesia at VMMC and Safdarjung Hospital. And ma'am's area of special interest are airway management and regional anesthesia. We welcome you, ma'am. This session will be moderated by Dr. Nidhi Yadav. Ma'am is Associate Professor in the Department of Anesthesia at ABVIMS and Dr. RML Hospital, with her areas of interest being pediatric anesthesia, BLS and ACLS training, and airway management. The case will be presented by a postgraduate student, Dr. Subbalakshmi, who belongs to RML Hospital. Over to you, ma'am, for the proceedings of the session.
Thank you, Dr. Nitin. At the outset, I would like to thank Dr. M.D. Kaur and her team for giving me this prestigious opportunity. And let's begin with the case presentation, Dr. Subbalakshmi.
Good afternoon, ma'am.
Good afternoon.
Ma'am, my patient, Mr. Ramesh, 63-year-old male, resident of Chanakyapuri, driver by occupation, presented with chief complaints of yellowish discoloration of eyes and skin for 3 months, loss of appetite and loss of weight for 3 months, generalized itching for 1 month. History of present illness. Patient was apparently well 3 months back when he noticed yellowish discoloration of eyes and skin, which was gradually progressive, no waxing and waning, associated with passage of clay-colored 3C stool, high-colored urine for the same duration. History of generalized itching since 1 month, which was gradually in onset, progressive in nature, relieved on medication. History of loss of appetite, loss of weight of around 5 kg since 3 months. History of easy fatigability present. History of nausea and occasional vomiting present, which is non-projectile, non-bilious, contains food particles. History of fullness after meals present. No history of prodromal symptoms like fever, joint pain before the onset of jaundice. No history of high-grade fever with chills or rigors and associated abdominal pain. No history of abdominal distension. No history of coughing on vomiters, black tarry stools, or bleeding from nose. No history of decreased vision at night, bone pain, frequent bruising, ecchymosis. Not a known IV drug user or prone to tattooing, does not have multiple sexual partners. No history of intake of steroids, herbal medications. No history of chest pain, cough, and breathlessness. No history of trauma, hematoma, or blood transfusion. Past history. Not a known case of diabetes mellitus, hypertension, bronchial asthma, coronary artery disease, tuberculosis. No previous history of jaundice. No history of drug allergy. No history of hepatobiliary surgical intervention. Personal history. Bladder and bowel habits are regular. Sleep disturbances present due to pruritus. No history of smoking, alcohol consumption. No history of substance abuse. Family history. Patient belongs to lower middle class family according to modified Kupaswamy. He lives with 2 children. Family history of jaundice. Treatment history. He is on tablet Udiliv, that is azodeoxycholic acid 150 mg since 3 months. General physical examination. Patient was examined in the sitting position. Patient was conscious, cooperative, oriented to time, place, and person. Patient looks slightly malnourished. Height is 161 cm, weight is 50 kg, BMI is 19.3 kg per meter square. Icterus present, pallor cannot be commented upon. No cyanosis, clubbing, lymphadenopathy, and pedal. No spider navy, palmar erythema, xanthelasma. On-skin scratch marks present over the abdomen and peripheries. Vitals. Pulse is 84 per minute, regular in rhythm, normal in volume and character, no vessel wall thickening, no radial or radiofemoral delay, all peripheral pulses are felt. Pressure is 112/72 mm mercury measured right arm in sitting position. Respiration is 14 per minute, regular abdominothoracic. Patient is afebrile, no engorged neck vein, no obvious spinal deformity present. Airway examination is normal. Intercessor gap is 5 centimeter. No artificial dentures, no loose tooth. Bifid Mallampati class is 1. Upper lip bitus class 1. Thyromental distance is 7.2 centimeter. Neck movement are normal. Abdomen examination. On inspection, contour of the abdomen is scaphoid. Yellowish discoloration of skin present, scratch mark present. Umbilicus is central inverted. No scar and no visible swelling, pulsation, or peristaltic waves. All quadrants of abdomen moving normally with respiration. Hernial orifice and external genitalia is normal. On palpation, on superficial palpation, abdomen feels soft, no local rise in temperature, no tenderness, no guarding or rigidity. On deep palpation, liver is just palpable, 2 finger breadth below the right costal margin, soft, non-tender with smooth surface and sharp margin. A 7 cross 4 centimeter firm, non-tender, globular, smooth surface lump in the right upper abdomen, moving with respiration and side to side. Its lateral, middle, and anterior margins are well defined, with upper margin continuous with the right costal margin. Spleen is not palpable, no palpable lymph nodes. Hernia sites, no cough impulse. On percussion, normal tympanic note all over the abdomen, no shifting dullness. Upper border of liver dullness at 5th intercostal space on right clavicular line. Auscultation, normal peristaltic sounds audible. CVS examination. On inspection, chest appears normal in shape, size, and symmetry. Precordium is normal in shape. Apical impulse visible. No engorgement of superficial veins. Carotid pulsation visible. Palpation. Apex present in left 5th intercostal space, half inch medial to mid-clavicular line. No parasternal heave. No appreciable thrill or pulsation in any area. On auscultation, normal S1 and S2 heard. Rate is 84 per minute regular. No murmur or added sounds heard. Respiratory system examination, inspection. Chest is normal in shape, size, and symmetry. Trachea is central. Respiratory rate is 14 per minute regular. Abdominothoracic. No accessory muscle use, nasal flaring, or subcostal retractions. No visible dilatations of veins, swelling, supraclavicular bulge, hollowing. On palpation, trachea appears in midline. Chest circumference is 78 centimeter. Normal chest expansion present. No local rise in temperature. No focal tenderness. On percussion, bilateral resonant percussion. Auscultation, vesicular breath sounds in all areas of auscultation. Added sounds, vocal resonance normal. CNS examination, patient is conscious, well oriented to time place person. No signs of confusion, lethargy, tremors, or hysterexis. Cranial nerve and motor nerve examinations are normal. Superficial and deep and reflexes are normal. Plantar reflexes flexor.
Okay. So, what is your provisional diagnosis, Dr. Subbulakshmi?
Yes, ma'am. My patient, 63-year-old male with obstructive jaundice, most likely of malignant etiology, ma'am.
Okay, first of all, you tell me what do you understand by jaundice?
Yes, ma'am. Jaundice is defined by yellowish discoloration of skin and sclera caused by increased serum bilirubin, ma'am.
Okay. So why? What are the sites where you look for bilirubin, and why is that so? Why sclera is
Yes,
a
ma'am.
prominent place for seeing jaundice?
Sclera is commonest site for looking jaundice, ma'am, because bilirubin has an affinity for elastin, ma'am. So sclera is
Okay.
common site. Other sites are palms, soles, skin, ma'am.
Floor of the mouth also we commonly see.
Under surface of tongue.
What is the normal value of bilirubin in our body?
Ma'am, 0.2 to 1 milligram per deciliter, ma'am.
Okay, very good. So now you've said that this is an obstructive jaundice. So what features in your history point towards obstructive jaundice?
Yes, ma'am. Ma'am, my patient is having clay-colored stool, high-colored urine, pruritus. So all these points towards obstructive jaundice in my case, ma'am.
So why they occur? So can you tell me in context of bilirubin metabolism?
Yes, ma'am. RBC are actually degraded in the reticuloendothelial cells and it releases hemoglobin. Heme is degraded into heme and globin. Globin is taken into circulation. Heme is degraded by a series of mechanisms, primarily by heme oxygenase, and biliverdin is produced. Biliverdin undergoes degradation by biliverdin reductase to form bilirubin. The formed bilirubin is actually not soluble in water. So the insoluble form binds with albumin in the circulation and it is taken by the liver. In the liver, it undergoes conjugation by UDP glucuronidase transferase to form bilirubin mono and bilirubin diglucuronate. The conjugated bilirubin then excreted into the biliary canaliculi. It reaches common hepatic duct, common bile duct, and it is excreted into the duodenum through ampulla of Vater, and it reaches the intestine. In the intestine, it is acted upon by beta-glucuronidase enzyme by the intestinal bacteria, where it is cleaved into urobilinogen and stercobilinogen. The stercobilinogen will impart a yellow color to the stools. The urobilinogen will be reuptaken by the circulation. Some of it goes to the liver, some excrete.
Tell me, so what is happening in obstructive jaundice?
Yes, ma'am. In obstructive jaundice, since the formed bilirubin that does not reaches the small intestine, so the urobilinogen.
Wait, what is the pathology in obstructive jaundice? Why this bilirubin is not reaching your numb?
Ma'am, the can be anywhere where it is not excreted into the biliary canaliculi. It can be at the site of either intestine, bile duct, anywhere in the pathway, ma'am. So the bilirubin doesn't reach the intestine, ma'am.
So it is not just bilirubin, beta, it is the bile which is not reaching. Bilirubin is entered into the bile of the which is present in the biliary canaliculi. So it is the bile, it is the obstruction in the flow of the bile, which can be in the liver at the level of excretion to the biliary canaliculi till the ampulla of Vater in the wall of the duodenum. Anywhere in this pathway, there can be an obstruction to the flow of the bile. Okay, so that is the main cause. Now tell me why there is, because of this obstruction, your history features are there. So bilirubin
clay colored is true.
Bilirubin is not reaching, bile is not reaching the intestine, so bilirubin is not reaching. So
stercobilinogen is not formed, so stools are clay colored, ma'am.
Okay, very good. So what about the yellowish discoloration of urine?
The bilirubin which is conjugated, it is not reaching the intestine. So the biliary pressure increases, it reaches the seismic circulation, ma'am. In the circulation, conjugated bilirubin being water soluble, it gets excreted in the urine. So high colored urine is present, ma'am. And also the conjugated bilirubin, regurgitated bilirubin will reach the systemic circulation, it gets deposited in the liver. Sorry, ma'am, but deposited in the skin and it causes pruritism.
Lakshmi, your voice is breaking, I think. I don't know, I hear whatever you're speaking is breaking to me. So what I was insisting here itself was that what is spilling into the circulation is not bilirubin. Because of the back pressure in the bile.
Entire bile, ma'am.
Bile is spilling into the circulation. So what are the constituents of bile? One is bilirubin, one is bile salt.
Bile salts, ma'am, and phospholipids, cholesterol, ma'am.
These other things. These are the three main constituents. So you said this is a conjugated bilirubin that has gone into the urine and imparted the yellow color. Now tell me, why pruritus is occurring?
Ma'am, first of all, the central opioidogenic receptors will be increased in obstructive jaundice, ma'am, and bile salts and the components will get deposited in the skin, ma'am. So that will cause pruritus.
The main cause is that bile salts are getting deposited in the skin, which is leading, and other histamine serotonin-like substances which are in the circulation, which lead to pruritus. Finish here. Okay. Now tell me, since the bile is not reaching the intestine, what other problems can occur to the patient?
Since bile salts are not reaching the intestine, absorption of fats will be decreased, ma'am. So that will cause steatorrhea. And further, the fat-soluble vitamins absorption is also impaired. So that will cause fat-soluble vitamin deficiency, ma'am.
For the fat-soluble vitamin deficiencies, and what problem occurs because of that?
Ma'am, fat-soluble vitamins are A, D, and E and K, ma'am. So it may cause night blindness, coagulopathy, bone pain. And
which one will cause coagulopathy? A will cause night blindness, loss of vitamin A.
A will cause night blindness. D will vitamin D deficiency will cause bone pain, hypocalcemia. Vitamin K deficiency
will cause
vitamin K will cause.
So have you ruled these out in your history? Are they present in your patient?
No, ma'am. no vitamin deficiencies
So,
present in my
you tell
patient.
me, okay, you tell me that vitamin K deficiency can occur and it can lead to coagulopathy. So what first of all, tell me, what are the features in your history you have taken to rule out coagulopathy? Any features, go back to your history. Have you
Yes,
taken any
ma'am.
history regarding coagulopathy?
Yes, ma'am.
Mhm.
Ma'am, there is no frequent bruising ephimosis in my patient, ma'am.
Okay, very good. Anything else? Can there be any gut manifestation? Can there be vomiting, which is you've taken a history? You've
Yes,
taken.
ma'am. There is no hematemesis. There is no melena in my patient, ma'am.
Okay. So right now we still don't know whether it is an obstructive jaundice. Can there be other causes of coffee ground vomitus or black tarry stools in your this thing, or bleeding from the nose? Can there be other causes of these?
Yes, ma'am. Ma'am, in advanced stage of liver cirrhosis, portal hypertension can occur and portal esophageal varices
Okay,
will
esophageal
cause.
varices, very good. Other causes of anemia like hemolysis, prehepatic anemia, hemolysis, hemolytic anemia, they can manifest. And in your patient, there can be in obstructive jaundice, anything in the gut, any ulcers can form in the gut.
Yes, ma'am. Stress ulcers are common in obstructive jaundice patient,
That
ma'am.
can
So,
lead to it. And suppose it is a malignancy, so any malignancy which can lead to melena or the black tarry stools.
yes, ma'am. Malignancy at the ample of Vater usually cause hemorrhage and necrosis, and it is,
Why it causes melena? There's
ma'am, the
slump.
hemorrhagic and stuffing of tissue into the duodenum that will cause melena, ma'am.
Yeah, into the duodenum. So there will be melena, and along with that, what will happen to the jaundice? Will it
Ma'am,
be
there will be vexing and waning of jaundice will be classical in these patients,
why?
ma'am.
Why?
Because the intermittent relief of obstruction, since the
Yes.
necrotic tissue is released
So
into
our
the
necrotic tissue is
duodenum.
sloughing off, so the obstruction to the bile flow is relieved. So there can be waxing and waning of the jaundice. So not now you tell me, why have you called this case as etiology of this jaundice as malignancy in your case?
Ma'am, my patient is having a significant loss of weight and appetite, and also it is a painless progressive jaundice, ma'am. And also in examination, the gallbladder is palpable, ma'am. So in a patient with obstructive jaundice, if gallbladder is palpable, the etiology will most commonly be malignancy, ma'am.
Not gallstones. This is which law? This is
Courvoisier's law,
also
ma'am.
law. Although it is called law, it may not be present in more than 25% of patients of malignancy. So very good. In examination also you have a palpable gallbladder. Why can't it be a malignancy of gallbladder itself leading to obstructive jaundice? Because your gallbladder is very smooth to palpate, smooth surfaces. Leaky gallbladder will have irregular nodular hard surface. Okay, we can leave that. So now tell me, why do you call it significant weight loss?
Ma'am, if the weight loss is more than 5% in more than 10% in 6 months, it is significant weight loss, ma'am. And my patient is having a weight loss of more than 5% in 1 month, ma'am. So,
Is there any malignancy which will not cause pain, which will also cause pain? You've said that this is a painless malignancy, so painless progressive jaundice, so you've called it as this thing. So now we know that there is a malignancy which is not progressive, which does not cause progressive jaundice, ampullary carcinoma, where waxing and waning can occur. Can there be a malignancy where pain can occur? Yes, pancreatic malignancy,
pancreatic
even cholangiocarcinomas can lead to pain. So it is not necessarily that all painless progressive jaundice are malignancy. Should know that. Now, you were saying that the pathology here you say is cholestasis. So what are the other causes of cholestasis that you know of besides malignancy?
yes, ma'am. It can be either intrahepatic or extrahepatic. Mostly extrahepatic causes are common bile duct stones, any strictures, ascariasis, uh,
Yeah.
or it can be intrahepatic causes are primary biliary sclerosis, primary sclerosing cholangitis, in viral hepatitis, advanced stage of cirrhosis.
Okay, very good, very good. Any familial causes which can cause stasis?
Yes, ma'am. Dubin-Johnson syndrome, Rotor syndrome.
Okay, very good. Any drugs which can
Without
cause
trans.
stasis? Any drugs? Drugs which can
Ma'am, steroids, erythromycin, OCPs, herbal medications, they can cause.
So you have taken a history to rule out drugs. I know you've taken history to rule out alcohol. What have you taken history of? Have you ruled out cholangitis or strictures in your biliary stricture? के लिए any history you've taken of a cholangitis?
Yes, ma'am. There is no history of any hepatobiliary surgical intervention in my patient, ma'am. So most commonly, stricture is caused by any injury to the bile duct biliary tree, ma'am.
Okay, there can be a previous iatrogenic injury which can lead to stricture. Okay, and all there
And
can.
cholangitis. Yes, ma'am. Cholangitis, I have ruled out by there is no history of any high-grade fever with chills and rigors or upper abdominal pain, ma'am.
So this is a Charcot's triad. What is Raynaud's pentad, which is present in cholangitis?
Ma'am, Raynaud's pentad, in addition to Charcot's triad, there will be mental confusion and shock in the patient, ma'am.
Okay, very good. So we have ruled out many causes of cholestasis. Now, can you tell me what are the other types of jaundice? And have you ruled out?
Yes, ma'am. The other causes, like, we can divide it into prehepatic, hepatic, and post-hepatic, ma'am. Prehepatic jaundice, most common cause is hemolysis, ma'am. That I have ruled out in my history because there is no history of any trauma, hematoma, or blood transfusion, which are the most common cause, ma'am. Because ma'am.
Why prehepatic jaundice is occurring?
Yes, ma'am. Because
what is hemolysis doing?
excess bilirubin is produced due to excess heme degradation, and that will exceed the capacity of the liver to conjugate, ma'am. So that will cause.
What kind of bilirubin is increasing in the circulation because of this?
Ma'am, there will be predominantly unconjugated hyperbilirubinemia.
Okay. So causes you are saying you ruled out are trauma, hematoma, malabsorption, and hemolysis by the previous history. Okay. What about the hepatic jaundice? What are the causes?
Ma'am, the most common cause are viral hepatitis, alcohol-related, drug-related, ma'am. So the classical symptom of viral-related hepatitis is there will be a history of fever with joint pain before the onset of jaundice, ma'am. The prodromal symptoms are absent in my patient, and also I have ruled out the most common cause of hepatitis B and C because my patient is not a drug abuser. He's not having any tattoos, and he doesn't have any promiscuous sexual behavior, ma'am.
Okay,
And there is no history of any alcohol or any other drug intake in my patient.
Now just tell me in brief, what are the investigations we do to differentiate between these three types of jaundice?
Yes, ma'am. Ma'am, prehepatic jaundice. There will be predominantly unconjugated hyperbilirubinemia. Urine urobilinogen will be excessively high, and the urine bilirubin will be negative, ma'am. AST, ALT enzymes will be normal, ma'am. Whereas in hepatic jaundice, both conjugated and unconjugated hyperbilirubinemia occurs, ma'am. The alkaline phosphatase also will rise, but it will not be like more than 2 to 3 times the normal, ma'am. And urine urobilinogen may or may not be positive, ma'am.
What are the transaminases in hepatocellular? You missed that, the most important thing.
Yes, ma'am. AST, ALT will be raised more than 6 times the upper limit of normal.
Okay, they'll be highly raised. You can say more than 6 times, okay, but they may be higher than that. They may be 10 times, 25 times as well. So they are highly raised in comparison to the alkaline phosphatase. And what about the post-hepatic or the obstructive jaundice?
Yes, ma'am. Ma'am, in obstructive jaundice, there will be predominantly conjugated hyperbilirubinemia. The alkaline phosphatase levels will be more than 3 times the upper limit of normal. Other enzymes like gamma glutamyl transferase nucleotidase will also be increased in this patient. And also the urine urobilinogen will be positive. Urine urobilinogen will be absent, and urine bilirubin will be present, ma'am.
Okay. Now tell me which transaminase is liver specific?
Ma'am, gamma glutamyl transferase, ma'am.
Transaminase. Transaminase.
Trans,
ALT and AST.
ma'am, ALT, ma'am.
ALT is liver specific enzyme. Okay. And about why alkaline phosphatase rises in obstructive jaundice so much?
Ma'am, it is alkaline phosphatase is present in the biliary canaliculi, ma'am. So, in obstructive jaundice, biliary pressure increases, and that will cause injury to the biliary canaliculi. So, alkaline phosphatase level will increase, ma'am.
Alkaline phosphatase is present in extrahepatic tissues also. What are they, and how will you differentiate that from the hepatic cause? I mean, the biliary, this thing, whether it is of biliary origin and of not.
Ma'am, alkaline phosphatase is also present in the bone, intestine, etc. Ma'am. So I will do gamma glutamyl transferase 5-nucleotidase enzyme. These are if they both are increased so much, it
Okay,
is
fine.
suggestive of liver origin, ma'am.
Now tell me, you've forgotten about any tests further which can differentiate between the two? Some biochemical tests, some synthetic function of
Pattern, synthetic function can be differentiated, can be identified by PTINR, ma'am. PTINR will be prolonged in both the patients, ma'am. In patients with hepatic jaundice as well as in with the patients with obstructive jaundice, ma'am.
so PT will be rising in the obstructive jaundice, you said, but what is the cause in the obstructive jaundice for the rise of PT or INR?
Yes, ma'am. The cause in obstructive jaundice is the decreased absorption of vitamin K, ma'am, being a fat soluble vitamin. So that will cause fat 27-9-10, which is vitamin K dependent clotting factor deficiency, ma'am. Whereas in hepatic jaundice, the synthesis itself will be decreased, ma'am. So obstructive jaundice patient will be responding to vitamin K administration, ma'am. Whereas hepatic jaundice patient will not respond.
Okay, very good. So, what is the half-life of coagulation factors? Will this PT prolongation in hepatic will tell you how early it can tell you about the synthetic loss of synthetic function of the liver?
Ma'am, factor 7 has half-life of 4 hours, ma'am.
So it is a PT is a very early marker of acute liver
The
disease.
marker.
Okay, what other synthetic function can be? What other thing can check the synthetic function of the liver?
Ma'am, albumin, ma'am. Albumin we decrease in either malnutrition or chronic liver disease, ma'am.
Okay, so in our patient, there is no liver dysfunction. So for hypoalbuminemia, cause can be malnutrition, right? What is the half-life of albumin?
14 to 21 days.
So what does it indicate? Low albumin indicates chronic liver disease, acute liver function. What does it indicate?
Ma'am, it cannot give a clue in acute liver dysfunction, ma'am. It can be of diagnostic value in chronic liver dysfunction.
Because its half-life is prolonged. So even
Because
today,
its half-life is.
if liver function stops today, the albumin will not fall till say 21 days or even longer. Okay. So what is the implication of hypoalbuminemia to us as anesthesiologists?
Yes, ma'am. One is our protein bound drugs will have a long duration of action, ma'am. Another one is hypoalbuminemia is associated with increased post-operative pulmonary complication, delayed wound healing.
Wait here. You said protein-bound drugs will have long duration of action. Before that, anything else? If in serum albumin is less in circulation, you give say thio is a highly protein bound, you give thiopentone. What will happen to the free form of the drug?
Increased free fraction of the drug will be there,
Your
ma'am.
initial drug dosage will be less. Duration will come later, right? So that is the most important thing. Okay, now tell me this bile, because of this bile flow obstruction, bile salts have reached the uh, bile salts have not reached the intestine. So one, you said that steatorrhea, fat malabsorption, vitamin K gone. Any other problem which can occur when bile salts are not reaching the intestine? Anything related to translocation?
Ma'am?
Bile salts
Yes,
are
ma'am. there will be a translocation of intestinal permeability will be increased, and because of the translocation of bacteria will be increased, ma'am. So there will be circulating endotoxemia in this patient, ma'am.
Okay, so that makes patient prone to sepsis,
Sepsis, ma'am.
right? There can be even because of this endotoxin spilling can also occur if there is intrahepatic bile salt accumulation in the liver. It can prevent the clearance of the Kupffer cells from the resident macrophage. Those endotoxin also spill into the systemic circulation from the portal vein, and they can lead to pro-inflammatory cytokine release and systemic inflammatory response, and gut derived sepsis and multi-organ failure can also occur. So in the there is also these things can also occur because of absence of bile salts in the intestine. Now tell me, what are the effects of bile salts in the reaching the systemic circulation on CVS, cardiovascular system, quickly?
Yes, ma'am, in cardiovascular system, bile salts get deposited in the conduction system, so it can cause bradycardia, ma'am. It also known to cause myocardial dysfunction, ma'am, and it causes decreased systemic vascular resistance and also decreases sensitivity to vasoactive agents, ma'am, and also decreases baroreceptor sensitivity, ma'am.
Okay, so what is the implication of this to us as anesthesiologists?
Ma'am, as an anesthesiologist, these patients are actually more prone for hypertension. So we have to adequately replace the losses as soon as it occurs, ma'am.
Okay, anything else? Just they're prone to hypertension because of hemorrhage. What about the cardiodepressant drugs?
Because of the anesthetic drugs also, ma'am. So we have to meticulously give titrated dose of all the anesthetic agents, ma'am.
So since there's left ventricular dysfunction present, can be present, have you ruled out anything in your history regarding that? Have you tried to see if your patient has dysfunction?
Yes, ma'am. There is no history of any chest pain, cough, breathlessness in my patient.
Breathlessness on exertion, है So can there be breathlessness in this case because of any other reason?
Ma'am, because of anemia also there can be breathlessness, ma'am.
Why there would be anemia in this patient?
Because of malnutrition.
Okay, so malnourishment can also lead to breathlessness, less muscle power, fatigability, easy fatigability, okay, and even metastasis in the lungs. Metastasis in the lungs can also lead to breathlessness. So there can be various causes of breathlessness. So from your history, you can't rule out whether it is because of left ventricular dysfunction. Now, very good. You have told me that, so in this case, it is very important to maintain the intravascular volume and promptly replace it. And we have, our myocardium is not very sensitive to the cardiodepressant drugs. So we have to titrate our doses, and your vascular responsiveness to the adrenergic agents like norepinephrine, angiotensin 2 is also abolished, whether endogenous or exogenous. So we have to take care or think of that also during our anesthesia. This is our anesthesia-related concern. So keep in mind, we are discussing anesthesia-related concerns as well. Now tell me the effect on the renal, kidney.
Yes, ma'am, renal blood flow is decreased primarily due to LV dysfunction and also due to circulating endotoxin that can cause renal vascular constriction, ma'am. So as such, renal blood flow will be decreased, and patients are more prone for perioperative renal dysfunction, ma'am.
Okay, any kind of hypotension, loss of volume, depletion, and renal flow. So it is renal flow is mainly affected because of hypotension or hypovolemia, which decrease the renal blood flow, and endotoxins also play a role in that. So we have to maintain the renal blood flow also, and same apply for the liver blood flow. Now tell me effect on the CNS.
The central opioid receptor activity will be increased, ma'am. So endorphins will be increased, opioid requirement will be decreased, ma'am. And these patients are more sensitive to the anesthetic agents, ma'am. So less amount of anesthetic agents have to be used.
What about inhalational agents? The serotonergic neurotransmission? Serotonergic neurotransmission in brain is decreased in obstructive jaundice. So patients are more sensitive to the effect of the inhalational agents as well. an endogenous enkephalin release. So maybe you have to decrease the doses of your opioids to half. Now, let us go on to the, suppose this question is posted now for, say, this patient is a patient for head of pancreas, carcinoma head of the pancreas, and posted for Whipple surgery. So tell me first, what is Whipple surgery? I mean, what are the, okay.
Whipple surgery involves a resection of gallbladder, proximal common bile duct, as well as distal part of the stomach, head of the pancreas along with ampulla, and proximal 10 centimeter of jejunum. And it is followed by hepatico-jejunostomy, choledocho-jejunostomy, gastro-jejunostomy, and pancreatico-jejunostomy.
Choledocho-jejunostomy is not there. You have to remove the CBD totally. So only there are 3 anastomoses. Hepatico-jejunostomy, pancreatico-jejunostomy, and gastro-jejunostomy. Only 3 anastomoses. So why do we need to know this? Why should we know the steps of surgery? Or how extensive is the surgery? Does it help us?
Yes, ma'am. Because
it helps us know that
sometimes
it could be a prolonged surgery, right? With so
it's a
many
prolonged surgery.
Okay, wait. Now, first tell me, what investigations would you like to do in a case before taking up this case?
Yes, ma'am. Ma'am, I would like to do a complete blood count, ma'am. Hemoglobin to rule out anemia and to have a baseline hemoglobin level, ma'am. And because of malnutrition, patient is more prone for anemia, and total leukocyte count to rule out any active infections, and plateline as a part of routine investigation, ma'am. And since these patients are more prone for perioperative renal dysfunction, I would like to have a urea creatinine and serum electrolytes level, ma'am. And I will do liver function test along with the serum proteins, ma'am. And I would like to do a coagulation profile in this patient. I would like to do a 12-lead ECG because this patient, since conduction abnormalities are common in this patient, I would like to do a 12-lead ECG. And 2D echo also I would like to do, ma'am, because this is a surgery involving large fluid shift, and LV dysfunction is common in obstructive jaundice. So I would like to do a 2D echo and chest X-ray, ma'am.
Okay. Sometimes there can be subclinical left ventricular dysfunction. So echo becomes important in that case also. We cannot say that patient doesn't have symptoms of breathlessness, so we won't do echo. We should do it's a subclinical LV dysfunction can also be present at times, and it's a big surgery involving a lot of fluid shifts and blood loss. So any other investigation would you like to do? Did you say X-ray test?
Yes, ma'am, I told.
For what? What would you like to see in X-ray test?
I would like to rule out lung metastasis.
Okay, very good. Anything, any other investigation would you like to see with surgeon would have done?
Yes, ma'am. Ultrasound and CT abdomen, ma'am. Ma'am, CT abdomen will give us clue the size of the tumor, and it will give us an idea about the operation time, ma'am.
So first, always ultrasound abdomen is done. This can guide you about the diagnosis, whether it is a malignancy, whether it is a stone, whether it is a stricture, and whether it is an intrahepatic or extrahepatic biliary dilatation. Only then you do the CT scan for location or extent of the staging of the malignancy or resectability of the tumor to assess that. There are now other non-invasive like MRCP investigation as well. Now we have discussed, I'll be asking you what are the anesthesia concerns. So tell me what are the 3 types of anesthesia concerns that we always divide our anesthesia concerns into.
Ma'am, I would look for patient-related concern, anesthesia-related concern, and surgery-related concern. Ma'am, the patient-related concerns are: one is patient is having a malnutrition, malignancy, so the risk of post-operative wound healing, stress ulcer, post-operative pulmonary dysfunction will all be increased in this patient, ma'am. And
So, what are the risk factors for this? Is besides this patient related, what are the risk factors for prediction of outcome after surgery?
Ma'am, bilirubin more than 11 milligram per deciliter, hematocrit less than 30%, malignancy are 3 important risk factors. Other than that, cholangitis, hypoalbuminemia, raised serum creatinine.
Okay, very good. The mortality becomes much higher if first 3 are If the first treat which you said, hematocrit less than 30%, serum bill and malignancy, then mortality is almost 60% if all three are present. Okay, fine. Now, what are the surgery-related concerns? What are the surgery-related concerns?
Surgery,
Yeah.
ma'am, it is one is hypothermia, and so it is a malignancy, so patient is more prone for DVT. So DVT prophylaxis is important, and it is a surgery involving large incision, so adequate anesthesia is important, and in a prolonged surgery, positioning is important, so adequate padding of pressure points is important in this case.
Very good. So what
And
type
also
of
sepsis prevention.
what? Pardon? Pardon? What did you say?
Sepsis prevention. Ma'am, sepsis prevention, ma'am.
Sepsis prevention. Okay. So, what kind of incision is there mostly for Whipple surgery?
Ma'am.
What kind of incision is there in Whipple surgery most of the time? Incision. Rooftop incision.
Ma'am, rooftop incision.
Okay.
Rooftop incision, ma'am.
There are also major fluid shifts and blood loss. They are also part of surgery-related concerns, as it's a prolonged surgery and bobble is exposed. Now, most of the anesthesia-related concerns we have discussed, right? You said that in the case we have discussed, renal we have discussed. Our goal is to maintain the renal blood flow and liver blood flow by preventing any hypotension or hypovolemia. Okay? You've discussed coagulopathy. PT can be deranged. Then you've discussed endotoxemia related to post-op sepsis, risk of infections. Then you've also discussed stress ulcer. Anything else which is left in the anesthesia-related concerns? What about fluid therapy?
Yes, ma'am. I will give a goal-directed fluid therapy. I will maintain intravascular volume. I will monitor urine output, and it should be more than 1 ml per kg per hour. I will give fluid accordingly.
What about the drugs, drug metabolism? Is it affected in obstructive jaundice?
Ma'am, metabolism will not be affected in obstructive jaundice, ma'am, but we have to take care of hepatic blood flow and drug which undergoes biliary excretion.
There are certain drugs whose metabolism is affected. There is biliary obstruction. What are they? Drug metabolism is affected. There are drugs which are the bile unchanged. What are those drugs?
Ma'am, beconium, rocuronium, ma'am.
Yes, why have you forgotten those? And also your CNS.
They are
two opioids and inhalation agents. So you have to decrease their doses. So these are your anesthesia related concerns. Okay, fine. So we've covered all three concerns. Now, suppose this patient comes to you in PSC about 1 week prior. His HB is 9.5, his serum bilirubin is 17, his INR is 1.7, serum albumin is say 3, and all other investigations are within normal limit. Now, how will you optimize this patient before the surgery? You have got 1 week.
I will build nutrition in this patient, ma'am. I will advise high carbohydrate, high protein, and low fat diet in this patient, ma'am.
Okay. Suppose patient is not able to take orally, then you already said
ma'am,
yes,
then I will,
right.
ma'am, then I will start nutrition and I will continue the same form, carbohydrate, high protein diet. It is also not possible.
Okay, fine. Suppose patient is anemic. Hemoglobin is 7. Would you like to transfuse blood in last 3-4 days left? Only 3-4 days are left before the surgery. Okay, yes, we would like to transfuse this patient, and the studies have shown that they improve the outcome of the patient. So because we've already said that hematocrit less than 30% is a very high predictor of perioperative mortality. Very good. So malnourishment corrected. What else you want to correct in this patient?
Ma'am, I want to correct coagulopathy, so I will give injection vitamin K 10 mg IV OD for 5 days to correct INR, ma'am.
2 to 5 days. If it was corrected in 3 days, well and good. Okay. So how much do you want to bring INR to?
At least 1.5, less than 1.5.
Okay, 1.5, fine. So you've corrected this. Now, what else you want to optimize in this patient?
Ma'am, bilirubin I would like to optimize. So in upper institute, ERCP and stenting is done, but in many institutes, injection mannitol 0.5 to 1 gram per kg, 20% is being given, ma'am.
These are two different things. Why are we giving mannitol to the patient? His bilirubin is 17. So what is the indication of giving mannitol, if at all you want to give, in these patients who've got such a high bilirubin? What value of bilirubin generally above which we give mannitol?
More than 14.
More than 8 is generally written. If it is more than 8, then we give mannitol. And what is the role of mannitol in these patients?
Ma'am, it decreases bilirubin overload in the renal tubules.
Yeah, you want to flush off the kidneys off, you flush off the bilirubin in the kidneys to prevent kidney injury, maybe, right? So you want to say that in your institution you give mannitol or you don't give mannitol? If you give mannitol, tell me what dose and how.
Ma'am, in our institute, we don't give mannitol, ma'am.
Okay, you don't give mannitol. Fine. There are studies which say that mannitol do not have even combined or alone with dopamine and furosemide do not cause much change in the outcome of the renal injury. But suppose I say that in our institution we are giving mannitol, so we give it in the dose of 0.5 to 1 gram per kg. Let's say 100 ml we can give of the mannitol, and then what is the concern with mannitol if you're giving? It is an osmotic diuretic. It can cause intravascular dehydration.
Hypotension.
Yeah, it can cause loss of intravascular volume, and it may be even more harmful if you don't replace the fluid. Fluid intake of the patient or the IV fluid has to be given along with it, right? So, okay, you were saying you don't want to give mannitol, but would you like to add some IV infusion to the patient? Would you like to add some?
I would like to give IV fluids.
Okay.
2 ml per kg per hour, ma'am, and I will monitor urine output. Okay. More than 1 ml per kg per hour.
To maintain the hydration input-output charting of the patient, kidney functions and electrolytes to be monitored. And another thing what you said was regarding oral bile salts. In your institution, you were giving.
Yes, ma'am.
Folic acid.
Our institutes.
Okay.
Yeah.
So why are they giving oral bile salts to these patients? To optimize what?
Ma'am, bile salts is found to be hepatoprotective, and it prevents liver injury, and it also aids in biliary excretion, ma'am. So because of that, in our institute that is given.
There is not a proven role or the validated role of its use, but if at all it is being used, it is hepatoprotective in cholestatic injuries, and it also increases the flow of the bile at times. It is known to increase. So these are all expected mechanism of action. And biliary drainage, which you are saying to decrease the bilirubin load, can be done with using a stent, but the latest guidelines, they say that it is a procedure which can cause a lot of morbidity and mortality because of the sepsis. So they say if the surgery is not far off, if it is only 1 week away, there's no need to put a stent. It increases the morbidity by causing sepsis and cholangitis more rather than protecting. So if there is surgery is imminent, please don't delay the surgery by doing a biliary drainage. So that is the guideline, but in your institute surgeons follow that. It is very all right. Okay, now tell me what what will we explain to the patient, and what pre-op orders would you write night before the surgery?
Yes, ma'am. Ma'am, I would explain the anesthetic procedure, and I would get an written and informed consent from the patient, and I will ask the surgeons to arrange an ICU bed for post-operative ventilation, and then I will ask them to get a blood and blood products ready. Then I will give NBO orders, 8 hours for solid food. If they are IV foods, if I'm not starting IV fluids, then carbohydrate drink is available commercially, ma'am. That can be given till 2 hours orally, ma'am. And then I will give injection alprazolam 0.25 mg per oral OD at the night of surgery. Injection pantoprazole 40 mg OD per oral. Sorry, ma'am. Tablet pantoprazole 40 mg OD per oral on the night as well as on the morning of surgery, ma'am.
What else?
And I would like to PPINR done within 24 hours of surgery, and I would like to get a serum electrolytes on the morning of surgery.
and you would like to arrange some blood or blood products as well. And if you're giving mannitol, that can be given 2 hours prior to the surgery, and intravenous fluids, finger lactate, or with some added dextrose, you can give at the rate of 2 to 5 ml per kg per hour overnight if you're using mannitol. And what is this carbohydrate drink that you're talking about? What is it? I think it is part of IRAS. What is IRAS, and what is the benefit of this carbohydrate drink to the patient? What is the benefit of this carbohydrate drink?
It is a Ma'am, the benefit is like it prevents hunger and it decreases insulin resistance in the patient, ma'am. So and it doesn't have any it doesn't decreases the pH also. So it is beneficial in
So,
these cases, ma'am.
carbohydrate drinks are part of IRAS. What is IRAS? It is enhanced recovery
It is
after
enhanced recovery after
surgery.
surgery, ma'am.
So, in the past, it said there is release of catabolic stress hormones, which cause insulin resistance, which leads to then protein breakdown and loss of muscle mass, which can be prevented in the post-operative period and help in early recovery. It also helps in preventing the hunger, thirst, and increases the well-being of the patient. And on the other hand, it also does not increase the gastric residual volume or decrease the gastric pH. Okay, very good. Now, what is your plan of anesthesia for this case?
Ma'am, my plan of anesthesia would be general anesthesia with endotracheal tube and controlled mechanical ventilation with thoracic epidural, ma'am.
Okay, very good. So why do you want to give thoracic epidural to this patient?
Ma'am, one is thoracic epidural is used for intraoperative and post-operative analgesia. It is also helpful in preventing post-operative pulmonary dysfunction because the incision is in upper abdomen, and also it is known to increase the intestinal microcirculation, so it prevents endotoxemia, ma'am.
Okay. Most important thing you've forgotten, it decreases the stress response to the surgery. It also decreases your risk of DVT,
Increases sympathetic.
decreases blood loss, decreases post-op ileus as well. And why it is decreasing the post-op complications? Because?
Ma'am, because of analgesia.
So analgesia से क्या होगा हमें? Post-op respiratory complication में क्या होगा? You have to tell the main thing. It will allow, because of the pain relief, it will allow breathing and coughing. The patient will be able to clear the pain. Less post-operative respiratory complication. Okay, but what is the concern in this patient if you're giving thoracic epidural? What you have to take care while giving this epidural?
Ma'am, I would like to prevent hypotension and bradycardia in this patient, which can be detrimental, ma'am. So I would give careful titrated doses of epidural.
Epidural, titrated doses of epidural. Titrated doses of
Epidural top-ups. Epidural top-up.
top-ups of what?
Ma'am, local anesthetic, ma'am. 0.25% bupivacaine.
You have to be very specific of what you are saying in exam. So you will, local anesthetic will cause hypotension or opioid will cause hypotension?
Ma'am, local anesthetic will cause hypotension, ma'am.
Higher,
So we will avoid.
You will avoid. Or you will see if it can be given. You can titrate your dose according to the patient status of volume status and blood pressure. Any other concern?
Coagulopathy has to be optimized, ma'am.
Yeah. Before starting the surgery, you optimize your PT, and later on, when you're removing the catheters, that time also you have to check your coagulation status, right? Okay. Now, what preparation you will do before taking the patient inside for the anesthesia?
Ma'am, I will check my anesthesia workstation. I will check the anesthetic as well as the emergency drugs, whether it's ready or not. I will check the warm IV fluids. I will check the OT table, and then I will check the NPO consent. And I will check the NPO and high risk consent.
That you've already done. Just tell me the OT things. DVT pump ready. What is the ambient OT temperature which you would like to have? Mostly it is 21 plus minus 3 degrees Celsius. You would like to keep your warm fluids, forced air warmers, etc. to be ready, right? and your
Yes,
defibrillator and working suction machine, etc., to be there. So now tell me what monitors, once you take the patient inside, how will you, what monitors will you attach to the patient?
ma'am, I would like to put a ECG, 5-lead ECG, then non-invasive blood pressure, SpO2 in this patient, and BIS monitoring, ma'am. And I will, under local anesthesia, I will take a arterial line in this patient, ma'am.
Okay, wait here. First, you said you want to put base monitor. Tell me why.
Ma'am, because these patients are more sensitive to anesthetic agents, so I want to give a
Anesthetic agent.
anesthetic agent such that it doesn't cause any hypotension or hemodynamic stability, ma'am. So I would monitor this, and according to that, I will give between 40 to 60. I will maintain, ma'am.
So patient is sensitive to opioids as well as inhalational agent and other CNS depressants. So you would like to do this. Why do you want to put an APPEC arterial line? Is it necessary in all cases of Whipple, or only in cases where there is a widespread tumor with extensive blood loss and fluid loss expected? Maybe in those cases, right? So you want, and maybe, but if you can prove your point that you want to put in all cases, just justify your answer. Why do you want to put an APPEC arterial line in this case? You can justify.
Ma'am, because while during induction, most of the anesthetic drug will cause hypotension, ma'am, and also laryngoscopy will cause sympathetic response and hypertension. So maybe I have to monitor these two. So I would put awake arterial line, ma'am.
Okay. So why sympathetic stimulation is bad for us? Hypotension, we all know.
Ma'am, yes, ma'am.
Hypotension, we all
Sympathetic
know,
stimulation will.
our goal is to maintain the liver blood flow and oxygen demand and supply, maintain the renal blood flow. Why sympathetic stimulation? What will that do? Will it also decrease the
Ma'am,
blood flow?
yes, ma'am. Sympathetic response will also decrease hepatic blood flow, ma'am.
By decreasing what? Portal venous blood flow or the hepatic artery blood
By
flow?
decreasing portal venous blood flow, ma'am, by splanchnic
Both have
vasoconstriction.
alpha receptors. Both can cause decrease in both portal vein. Okay. Now here, examiner can also ask you about the liver blood supply and other things. I will also ask, but wait here. Now let me finish the monitoring. So arterial line awake, you've told me the correct reason. So I will allow you to put an arterial line in all cases of obstructive jaundice. Any other monitor which you would require? Any other monitoring? CVP would you like to do?
Central venous pressure, that post-induction I would like to put, ma'am.
Okay, very good. Any time I'm asking, just tell me the monitors. They can be pre-induction or post-induction.
Yes, ma'am. Then temperature monitoring, urine output monitoring, TCO2 monitoring I would like to put.
Okay, very good. Anything else you would monitor in between? It's a long surgery with lot of
Ma'am, I would like to monitor blood glucose and frequent ABGs, ma'am.
Okay. So that will, what would you see in the ABG?
Ma'am, ABG, I would like to measure the serum lactate levels, ma'am, because in any hypoperfusion state, lactate will be increased.
Oh, very good. We are short of time, Subba Lakshmi. Let's go on with the GA part. Tell me, what will you, how will you induce this patient now? Quickly.
After putting thoracic epidural, I will pre-oxygenate the patient with 100% FiO2 with a tight fitting mask for 3 minutes, and then I will give injection midazolam 1 mg IV, and then I will give injection fentanyl 2 mics per kg IV, and then I will give graded dose of injection propofol till the loss of verbal response occurs, and then I'll check for bag and mask ventilation. If I can able to ventilate the patient, then I will give injection atracurium 0.5 mg per kg IV, ma'am. And after 3 minutes, I will intubate the patient with cuffed endotracheal tube, and I will put it on the ventilator, ma'am. And I will start inhalational agents after checking the PP, ma'am.
Inhalation agent would you prefer?
Ma'am, I would like to prefer sevoflurane in this case, ma'am.
Why?
Ma'am, because among the inhalational agents, halothane will decrease the hepatic arterial buffer response, ma'am.
Okay.
All three agents will not abolish the buffer response. And since isoflurane and desflurane will produce trifluoroacetic acid, which is hepatotoxic, I will go for sevoflurane, which doesn't produce TFA, ma'am.
Okay, you've justified your answer. I'm okay with it. Now tell me, what is HABR, hepatic artery buffer response, quickly.
Ma'am, liver is supplied 80% by portal vein and 20% by hepatic artery, ma'am. But if by any cause portal vein supply is decreased, then hepatic artery blood flow will be increased to compensate for that, ma'am. That is a hepatic artery buffer.
But the reciprocal is not good. Now you said you would use propofol. Can you use thiopentone? Why do you prefer?
Yes, ma'am. Thiopentone also I can use.
This patient, the serum albumin is not decreased, liver function is not deranged. So you can use propofol as well as thiopentone, taking care that you get titrated doses and do not cause fall in blood pressure. That is the most important part. Okay. So that is where you put your awake arterial line as well. So you have to do these monitoring, give very titrated doses slowly. What is the one-arm vein circulation time? That is for thiopentone. How much time does propofol take to titrate? Takes about 90 seconds. 90 seconds for propofol. So most of the time we don't wait for that long and then we give more propofol and cause hypotension. So you have to give low and intermediate doses of propofol. That means that to titrate it to the loss of verbal contact. Now tell me, would you like to give? You said you will give etracurium. What is the advantage of etracurium? Is there any other choice you have in muscle relaxation?
Cisatracurium is more better than atracurium because it is more potent and it causes histamine release and it doesn't produce much laudanum as compared to atracurium.
What is the harm with laudanum?
Man, laudanum causes seizures.
Okay, accumulator, if accumulator. Why not roxiconium and vecuronium?
Ma'am, they both are most like 70%, 40 to 70% are excreted as parent compound in the bile, ma'am. So the duration of action will be prolonged and recovery will be delayed, ma'am.
You can monitoring these missed was neuromuscular monitoring that can also be done in all these cases. Okay, and what are you using for your maintenance of gases, oxygen, nitrous, and would you like to use nitrous? You can use nitrous because if you don't use nitrous, then you'll have to increase the doses of your inhalational agent, which can further cause hypotension. Already your peripheral vascular resistance is decreased. You want to give epidural, you're giving cardiosuppressant drugs, right? So, okay, now just tell me, your time over. We've just taken 1 hour. Okay, one last thing. Once you want to reverse this patient, what other things would you like to check and ensure?
Ma'am, I will check the hemodynamic stability and if I will check whether the blood loss has been adequately replaced and if patient is not hypothermic, I will extubate the patient, ma'am.
So you'll check for fluid, electrolyte, hypothermia, normoglycemia, urine output adequate, ABG electrolytes within normal limit, everything. And then you would like to extubate if there's not been a lot of blood loss, if the patient is stable. And you would monitor this patient in ICU. Otherwise, this patient can be shifted to ICU for further management. So here we can finish our case. I think Subbalakshmi did very, very well. Thank you so much, Dr. Subbalakshmi. I can also say that this is a very, very important long case for exams. You may also be asked about structure of liver, functions of liver, other things like CTP, MELD scoring, causes of post-operative jaundice, hepatorenal syndrome. Some examiners are fond of asking this even in cases of obstructive jaundice. Even how to palpate liver and spleen can be asked. Thank you. Over to Dr. Niti Yadav.
Yes, ma'am. I'll just share my presentation. Good afternoon, everyone. Now we will summarize whatever we had learned in the last 1.5 hours. The patient with obstructive jaundice, which is positive for Whipple surgery. The liver and the biliary system. Liver is the largest internal organ, weighing around 1.7 kg in an average adult male. It's located in the right upper quadrant beneath the diaphragm and protected by the rib cage. It is divided into right and left lobes and further divided into 8 segments. The functions of liver are the liver helps us in protein metabolism, carbohydrate metabolism, lipid, heme and bilirubin metabolism of various drugs, synthesis of albumin and various clotting factors. It has an antibacterial action and it acts as a reservoir of blood, the blood being stored in the liver sinusoids approximately 400 to 600 ml. Liver helps us in glucose hemostasis, in fat metabolism by breaking down into by helping in fatty acid oxidation and synthesis of triglyceride, lipoproteins and cholesterols. It helps in metabolism of various drugs and hormones and bilirubin formation. The hepatic blood supply. Liver is the organ which gets dual blood supply, 25 to 30% of the cardiac outputs being supplied to the liver through the hepatic artery and the portal vein. Hepatic artery supplies 25 to 30% of the blood to the liver, and the oxygen content which is consumed by the liver is approximately 45 to 50%. The portal vein supplies 70 to 75% of the blood supply to the liver, and the oxygen content which the liver uptakes is around 50 to 55%. So overall, portal vein supplies 2/3 of oxygen to the liver. As I told you earlier, liver acts as a reservoir of blood, the reservoir being the sinusoids, which can store approximately 400 to 600 ml of the blood. Now coming to the metabolism of bilirubin. The senescent erythrocytes, in them, the hemoglobin is broken down into heme and globin. The heme then further converts into biliverdin, and then biliverdin is further converted into bilirubin. This bilirubin is then presented to the liver, where it gets conjugated to form bilirubin monoglucuronide and bilirubin diglucuronide. This bilirubin mono and diglucuronide then, through the bile and the bile ducts, it reaches the intestine, where by the action of colonic bacteria, the glucuronide base is removed and it is converted into urobilinogen and stercobilinogen. Some of this urobilinogen is then reabsorbed again, and through the portal vein, it goes back into the liver and then further excreted into the kidneys, where it forms urobilin. This going back of urobilinogen from the intestine to the liver, then its further metabolism is known as enterohepatic circulation. Liver function test can be classified as a test which help us know about the excretory capacity of the liver, the biosynthetic capacity of the liver, any injury to the hepatocytes and cholestasis. Excretory capacity of the liver can be judged by serum bilirubin levels, urine bilirubin levels, and urine urobilinogen levels. The biosynthetic capacity of the liver is assessed by albumin levels, prothrombin, alpha-fetoprotein, and ceruloplasmin. Injury to the liver can be gauged by doing the aminotransferase level, which are AST and ALT. And cholestasis can be diagnosed by doing alkaline phosphatase level, gamma glutamate transpeptidase levels, and 5' nucleotidase levels. Now coming to jaundice. What is jaundice? Jaundice is a yellowish discoloration of body tissues resulting from the deposition of bilirubin, which usually is greater than 2 mg/%, which occurs in the presence of serum hyperbilirubinemia. The most common site of hyperbilirubinemia or jaundice is sclera, because the sclera has the elastin tissue which has increased affinity for bilirubin. The undersurfaces of the tongue, palms, soles, and various skin surfaces. Now coming to the types of jaundice. Jaundice can be classified as prehepatic, hepatic, and posthepatic. Obstructive jaundice comes under posthepatic. Hepatic is also called as hepatocellular jaundice, and then prehepatic jaundice. Prehepatic jaundice, in this excessive amount of bilirubin is presented to the liver due to the excessive hemolysis, which overpowers the conjugating capacity of the liver. That's why there is increase in level of unconjugated bilirubin in the serum, and most common example is hemolytic anemia. In hepatic or hepatocellular jaundice, there's impaired cellular uptake, defective conjugation, or abnormal secretion of bilirubin by the liver cells. In this, both conjugated and unconjugated bilirubin may be elevated in the serum. The most common cause are viral hepatitis A, B, C, alcoholic hepatitis, and drug toxicity. Post-hepatic jaundice, there's impaired excretion due to the mechanical obstruction of the bile flow. Since the bilirubin has already been conjugated by the liver, so in the post-hepatic jaundice, there is mainly increase in the conjugated bilirubin levels in the serum. The most common cause being gallstones, malignancy, inflammation, strictures, parasitic infections. The various tests which helps us to diagnose, differentiate between prehepatic, hepatic, and post-hepatic jaundice. The first one being the aminotransferase, which are AST or ALT. In prehepatic jaundice, the aminotransferases levels are normal. In hepatic jaundice, there is increased, but there's very high increase, but and may be normal or decreased in advanced stages as the complete liver is destroyed. In the post-hepatic jaundice, aminotransferase level may be normal during the early stages, but they get increased in the advanced stages. Alkaline phosphatase, it is normal in prehepatic jaundice and minimal rise, which is approximately 2 to 3 times in hepatic jaundice, whereas in post-hepatic jaundice, there's marked increase in alkaline phosphatase level, which will be more than 3 times. It is approximately 3 to 10 times. Bilirubin level, which is assessed by using Van der Berg test, is increased. The unconjugated bilirubin is increased in prehepatic jaundice. In hepatic jaundice, there is both the bilirubins are increased, whereas in post-hepatic jaundice, there's mainly increase in conjugated bilirubin levels. Serum proteins are normal in prehepatic jaundice. They are decreased in hepatic jaundice as liver is a synthetic organ for synthesis of the serum proteins. And in post-hepatic jaundice, the serum proteins level are normal in the early stages, but it may be decreased in advanced stages. Prothrombin time is normal in prehepatic jaundice, whereas in hepatic jaundice, it is normal in early stages and prolonged in the late stages. As same with post-hepatic jaundice, it is normal in early stages and prolonged in the advanced stage. Blood urea nitrogen is normal in prehepatic jaundice, whereas in hepatic jaundice, it is normal, decreased in the advanced stages, and post-hepatic jaundice have a normal blood urea nitrogen. Sulfobromophthalate is a dye which is used for testing the liver capacity. It is normal in prehepatic jaundice. In hepatic jaundice, there is retention of this dye, means the transport proteins which are required for excretion of this dye, and they are absent. And in post-hepatic jaundice, there is sulfobromophthalate test may be normal or where there is a retention in the advanced stages. Further tests are urine urobilinogen levels. In prehepatic jaundice, it is high. In hepatic jaundice, it is urine bilirubin is present, whereas in post-hepatic jaundice, urine urobilinogen is absent. Urine bilirubin is absent in prehepatic jaundice. It is present in hepatic jaundice, and it is also present in post-hepatic jaundice. Urine bile salts and bile pigments are present in post-hepatic and hepatic jaundice, whereas they are absent in prehepatic jaundice. Stool stercobilins are high in prehepatic jaundice. They can be found in hepatic jaundice, whereas in post-hepatic jaundice, they are absent. Gamma glutamyl transpeptidase and 5' nucleotidase levels are increased in post-hepatic jaundice, whereas they are normal in prehepatic and hepatic jaundice. The various causes of obstructive jaundice. The causes of obstructive jaundice can be classified into intrahepatic causes and extrahepatic cause. The intrahepatic cause mainly being viral hepatitis, alcoholic hepatitis, and drug toxicity. Some lesser known causes are primary biliary cirrhosis, primary sclerosing cholangitis, cholestasis of pregnancy, genetic causes, various veno-occlusive diseases, paraneoplastic syndromes, and infiltrative disease, example, tuberculosis, lymphoma, and amyloid. The extrahepatic causes are mainly malignant, which include periampullary carcinoma, cholangiocarcinoma, pancreatic cancer, gallbladder cancer. The various benign causes are choledocholithiasis, post-operative biliary strictures, chronic pancreatitis, rare causes being AIDS cholangiopathy, primary sclerosing cholangitis, and worm infections, ascariasis. How to clinically differentiate between the various causes of obstructive jaundice, which are mainly gallstone, cholangitis, and malignancy. Obstructive jaundice due to gallstone, which present with colicky pain in the right hypochondrium that is aggravated with fatty meals. It is often associated with fullness and bloating. Obstructive jaundice due to cholangitis, patient presents with a Raynaud symptomatology which is called as Raynaud's pentad, which includes septic shock, mental retardation, fever, abdominal pain, and jaundice. The triad of fever, abdominal pain, and jaundice is also known as Charcot's triad. There's no significant relation with meals. Patient may give history of ERCP, surgery, parasitic infections, which may be usually present. The obstructive jaundice, which is caused due to malignancy, is associated with signs significant weight loss, very gradual, progressive increase in nature of bilirubin. Patient may present with itching. There is known tender swelling can be felt in the abdomen. Drugs which can cause cholestasis are anabolic steroids, erythromycin, rifampicin, estrogens or oral contraceptive pills, tamoxifen, azathioprine, chlorpromazine, and carbamazepine. What are the investigations and their purpose? This, other than doing the liver function test and various investigations listed earlier, we can get urine for urobilinogen and urine bilirubin levels to differentiate between various types of jaundice, whether it is prehepatic, hepatic, or posthepatic. USG abdomen for free fluid in the abdomen, and USG abdomen is a diagnostic for gallstone. ARCP, it is invasive, but it is useful in stenting for the stone removal. CT with contrast can be done to know about the pathology, how much extent it is, but since contrast is used, it can be harmful. So a non-invasive investigation like MRCP can be done. Liver function tests such as AST, ALT, ALP, total bilirubin, direct bilirubin can be done to know about the pattern of the disease. Serum albumin, albumin globulin ratio, prothrombin, INR to assess the synthetic function of the liver. Complete blood count, including platelet count, bleeding time, clotting time to assess the general condition of the patient. Kidney function test to rule out pre-renal or renal acute kidney injury. ECG to rule out conduction abnormalities, arrhythmias as a result of several factors like hyperbilirubinemia. 2D echo can be done to check for clots, hypercoagulability due to cancer, metastasis, etc. Upper GI endoscopy to check for esophageal varices and check the periampullary bulge. USG abdomen to check for ascites, nature of biliary ducts, and to diagnose stones. Chest X-ray pre-A view, posterior anterior view to check for pleural effusions, metastasis, etc. And CT scan to diagnose obstruction to biliary flow. What is the effect of drugs on liver function? The volatile anesthetic agents. Most anesthetic agents decrease the portal blood flow because of decrease in the cardiac output. Hepatic artery buffer response is preserved with all agents except halothane. Halothane is associated with halothane hepatitis. So the anesthetic agent that needs to be avoided in a patient with obstructive jaundice is halothane. Sevoflurane does not produce trifluoroacetic acid intermediates, and compound A produced with sevoflurane anesthesia is not hepatotoxic. Extent of the tissue metabolism is least with isoflurane and desflurane. IV induction agents, the clearance of thiopentone is not altered. High volume of distribution, low rate of hepatic clearance, it can accumulate if given in large doses. So the doses need to be decreased in case of obstructive jaundice. Propofol may reduce hepatic blood flow. Prolonged infusions is avoided in hepatocellular injury. So titrated doses of propofol need to be given if you are choosing this agent for induction of anesthesia. Ketamine and etomidate have high extraction ratio, highly lipophilic, and clearance in cirrhotic is similar to normal patients. What about opioids? Morphine metabolism is reduced. There's prolonged elimination. There's decreased plasma protein binding that leads to increase in the active form of the drugs. That's why the dose of morphine needs to be reduced by 50%. Meperidine clearance of meperidine, the clearance of its metabolite normeperidine is also reduced, and that can lead to, if accumulated, can lead to neurotoxicity. Fentanyl and sufentanil, they have no appreciable effects. So these are the preferred agent. Remifentanil metabolism is organ independent, so it is unaffected in obstructive jaundice. Sedative hypnotic drugs like midazolam, they have increased free fraction of the drugs and reduced clearance, and Dexmed has increased free fraction. Dose reduction need to be followed. What about muscle relaxants? Succinylcholine and mivacurium, their action is prolonged due to the decreased plasma cholinesterase activity. So their dose need to be titrated, and neuromuscular monitoring should be done to know about their effects. Vecuronium and rocuronium, they have decreased clearance and prolonged elimination time. Atracurium and cisatracurium are the preferred agent as their metabolism does not depend on liver and kidneys. The synthetic capacity of the liver, which is diagnosed by prothrombin time. Prothrombin time collectively measures the activity of various factors like 2, 7, 9, and 10. And biosynthesis of factor 2, 7, 9, and 10 is dependent on vitamin K. Since a liver is damaged, so there is deficiency of vitamin K, so there is deficiency of vitamin K dependent clotting factor. When compared to albumin, liver-derived procoagulants have short half-lives, which range from 4 hours for factor 7 to 4 days for fibrinogen. Plasma levels of such procoagulants will start to decrease very rapidly within 4 hours if the liver begins to fail. A prolonged prothrombin time secondary to liver failure reflects a low blood level of factor 7A, which has the shortest plasma half-life of 4 hours. The cardiovascular effects of jaundice on the cardiovascular system. There's bradycardia due to deposition of bile salts in the SC node, which leads to conduction abnormalities. There is decreased myocardial contractility. There is impaired cardiac contractility, decreased responsiveness to various vasoactive substances. There is decreased peripheral vascular resistance and LV dysfunction. These all factors will lead to depressed function of the reticulum. They leads to hypotension and bradycardia, which is also called as jaundice bradycardia. What about immune system? There is defect in cellular immunity. The functions of reticuloendothelial cells, that is Kupffer cells, is depressed. There's impaired T cell proliferation and decreased neutrophil chemotaxis, defective bacterial phagocytosis. Portal and the systemic endotoxemia can lead to severe sepsis, wound dehiscence, and wound infections. And the other causes of sepsis are cholangitis and bacteria present in the bile. What happens to the renal system? There's an increased incidence of acute kidney injury, which is mediated primarily due to decreased responsiveness to vasoactive substances as well as decreased myocardial contractility, and secondarily due to endotoxemia as a result of both sepsis and loss of bile salts to the vascular space. Kidney injury is exacerbated by induced diuresis and impaired myocardial contractility. Refractoriness of the tubule to antidiuretic hormone and increased level of atrial natriuretic peptide resulting in hypovolemia. Net result is renal vasoconstriction, hypoperfusion, the shunting of blood from the cortex, and activation of complement system, which leads to tubular and cortical necrosis. There's deranged coagulation because there is reduced synthesis of the clotting factors, which leads to prolongation of the prothrombin time. Vitamin K deficiency due to biliary obstruction. There is defective gamma carboxylation. There is deficiency of vitamin K dependent factors. Endotoxins, hypersplenism, they lead to thrombocytopenia. Endotoxins also called increased fibrinolysis and low-grade DIC, and there is loss of calcium. What is the surgical surgery for periampullary carcinoma? Is Whipple surgery. It is mainly a resection of the cancerous part of the pancreas, duodenum, common bile duct, and gallbladder. and the distal stomach. The three anastomosis which are performed is hepaticojejunostomy, gastrojejunostomy, and pancreaticojejunostomy to re-establish the bile flow, the gastric flow, and the pancreatic juice flow. What are the anesthetic consideration in this patient who is posted for Whipple's procedure? Concerns due to surgery. Since it is a major surgery, there's a long duration, there's increased blood loss and fluid shift. The incision is rooftop incision, which means it extends from one subcostal, goes up to the epigastrium and goes to the other side in the subcostal region. So since a large incision, so postoperative analgesia is very important. And if we plan for thoracic epidural, so epidural blockade should not go above T5, which can lead to decrease in the hepatic blood flow. Disease-related concerns. Since the synthetic capacity of the liver is decreased, so there is hypoproteinemia and reduced level of drug binding. That leads to reduced level of the drug binding proteins. There's altered volume of distribution and increased total blood volume. There's coagulopathy due to deficiency of vitamin K and vitamin K dependent clotting factors. There's alteration in drug metabolism and clearance. There's hypoglycemia, electrolyte imbalance, anemia, leukopenia, and thrombocytopenia due to hypersplenism, deficiency of fat-soluble vitamins A, D, E, and K due to malabsorption, and increased serum cholesterol and atheromatous changes. Concerns due to particular disease on the other system involvement. In cardiovascular system, there's increased bilirubin bradycardia occurs, and there's impaired contractility and decreased peripheral vascular resistance, which leads to increased chances of hypotension and shock. And respiratory system, it leads to arterial hypoxemia and increased arterial hypoxemia. In renal system, due to hypotension and hypoperfusion, it can lead to pre-renal failure, and in advanced stages, pre-renal azotemia and hepatorenal syndrome. What are the patient-related factors? Main risk factors are age greater than 60 years, albumin level less than 30 gram%, pre or renal dysfunction, long-standing biliary obstruction, weight loss, and increased serum creatinine and sepsis. They are the prognostic factors, and increased perioperative cardiovascular collapse and renal failure. Predictors of poor perioperative outcome in patient with liver disease is Child-Pugh Stokes class C, MELD score is 15 or more, acute hepatitis, chronic active hepatitis, abdominal surgical procedures, and PT prolongation of 3 seconds or more. What is the perioperative management of a patient which is posted for Whipple's procedure? First, we go into history of symptoms of fatigue, anorexia, weight loss, nausea and vomiting, pruritus, easy bruising, dark colored urine and clay colored stools, biliary colic, and abdominal distension. Alcohol consumption, use of recreational drugs, medications, presence of tattoos, high risk behavior, previous history of jaundice in relation to surgical procedure, and blood transfusion should be sought out. Preoperative optimization, avoid prolonged hyperbilirubinemia. For this, stenting can be done, which is usually done 2 weeks prior to the surgery. Treat infections and cholangitis with broad spectrum antibiotics. Improve nutritional status of the patient by giving per orally. If per orally is not, you should give enteral nutrition. If enteral is not feasible through the mouth, you should give it through a jejunostomy tube. And if at all enteral route is not possible, you should give parenteral nutrition and start it total parenteral nutrition, which is you should start 5 to 7 days prior to the surgery. You should correct the electrolyte imbalance, correction of anemia and the coagulopathy by giving vitamin K 5 to 10 mg for 3 days prior to the surgery. Coagulopathy due to vitamin K deficiency, factor deficiency, thrombocytopenia should all be corrected. TEG can be used if available. It can be used to guide on the blood product transfusion. Synthetic failure, transfuse FFP and aim for an INR of less than 1.5 and avoid pre-renal failure. Use aminoglycoside to avoid pre-renal failure. Use aminoglycoside antibiotic carefully. Avoid all the NSAIDs. If bilirubin level is greater than 8 mg%, IV fluid should be started at the rate of 5 to 10 ml per kg per hour. And mannitol can be given in a dose of 0.5 to 1 gram per kg of 20% solution 2 hours prior to the surgery. Arrange for adequate blood and blood products. In preoperative medication, anxiolytic should be given, which should be given which are usually short-acting. Example, IV benzodiazepines. Anti-aspiration prophylaxis with H2 receptor blockers and metoclopramide. And on the morning of surgery, prothrombin, INR, and serum electrolyte should be done. What are the goals? Goals are minimize physiological insult to the liver and the kidney, maintain oxygen supply demand relationship to the liver, adequate pulmonary ventilation and cardiovascular function, maintain renal perfusion, avoid hypotension and sympathetic stimulation and hypoxia, meticulous fluid balance, and choose appropriate anesthetic agent, metabolism of the drugs, plus
can I please interrupt you? I'm getting message from the organizers that it has been a very, very long talk. We would like to finish off here only. And the forum is open to the organizers if there are any questions in the chat box.
No questions, ma'am.
Okay, thank you so much.
Thank you, ma'am.
Thank you.
Thank you, ma'am.
Thank you, Dr. Nidhi.
Thank you so much, ma'am, for being part of APPEC2023. Thanks to Nidhi, ma'am, for her presentation.
Thank you. Thank you, Dr.
So we'll move on to our next session. I would like to invite the chairperson for this session, Dr. Sanjeev Aneja. And sir is working in Indraprastha Apollo Hospital, New Delhi. Over to you, sir, for the proceedings of the session. We welcome you, and over to you, sir.
Good afternoon, everybody. First of all, I would like to thank the organizers for giving me the opportunity to chair this session. And then they have chosen one of the best speakers for this program.